It has various associations, not causes, associations. And the associations are essentially diabetes, alcoholic liver disease. Now, that's really the cause of liver disease in our country. So it's a liver disease which is really the problem. But because alcoholism is the main cause of liver disease, that's why alcohol is relevant in the etiology. It's also associated with epilepsy, smoking, and so we used to find it quite a lot in the old TB hospitals in Switzerland. But the most common thing you find is that it's genetic and someone has it in the family. There are also some other things. It's supposed to be common in thinner people. It's also commoner in people who have had some kind of hand trauma in the past. There is controversy as whether it's associated with vibrating tools, and I don't know whether that's the case or not, but the evidence is not that clear. This particular patient that we're talking about here is obviously a chap, and he's got disease in his left hand, which is not so bad, but it's in his right hand, which is really quite severe. It's affecting the ring finger, and the ring finger is the most common finger to be associated with Dupuytrens. So if we talk about perhaps how I would, or what treatments I would offer the patient with his left hand to start off with, and then we'll talk about the right hand, because the right is a significantly different kettle of fish. So looking at that, it's a little bit difficult to see what the deformity is, but he wouldn't be able to put his hand flat on the tabletop. Now that is the Houston tabletop test. It's got nothing to do with Houston in America. It's about a guy in Melbourne in Australia. But basically, if you can't get your hand flat on the tabletop, that probably is a good indicator for you should be operating on someone, because at that stage, a bloke will end up picking his nose when he shaves, and a lady will end up not being able to put her gloves on. So it looks, although there's probably an MPJ contracture in this chap's left hand, probably about 60 degrees, I think, something like that. Obviously we can't see the lateral. However, there's a single band going down to the finger. It's only an MPJ contracture, and thus there are three things that you can do. And basically, if I was sitting in front of the patient, I would be offering them and giving them all the solutions, all the potential solutions that I can give, and then saying, okay, let's make a decision mutually. So things you could do: percutaneous release. This is done on local anaesthetic and you use a blade use a needle as a blade, and that's done in the clinic, and it will correct that deformity, and it should correct that MPJ deformity completely. The problem with that is the fact that the recurrence rate is very high, and the recurrence rate of 5 years is about 80–85%. The other option, which I think you've got to talk about, although I can't give it on the NHS, is Xiapex, or the collagenase. Again, this is a very similar thing. It's actually directly destroying a bit of the tissue, and it dissolves a bit of the tissue. But that has got a recurrence rate of probably about 66% at the PIPJ, and so at the MPJ slightly less. But so we've got 85% recurrence rate for the percutaneous and 60–70% recurrence rate at the MPJ. The reason I'm sure the recurrence rate is there is the fact you're not taking the disease out. If you cut the band, you leave the disease. If you dissolve a bit of the band, you leave the disease. So I think the recurrence rate is less if you do formal surgery. So the formal surgery for that, I would do a longitudinal incision all the way down the finger. I would break up my incision when I close it by doing some Z-plasties. You tend to do that over the finger where there's most fatty tissue. That's over the proximal phalanx. That's where I do my Z-plasty. I would do what I call a giving incision proximally, which means I make a transverse incision which I leave open, and that will heal by secondary intention. It only takes about three weeks to heal, but I would be taking as much of the disease out as I possibly can, and my recurrence rate for that would probably be I quote about 25%. But I think it recurs in everybody, whatever you do. But I do think the more disease you take out, the less the recurrence. This chap's right hand is a little bit of a different kettle of fish, and we've got a significant PIPJ contracture. So the spiral cord is very likely to be involved here. The spiral cord is a bit of disease that goes from the central cord, it goes down the side of the finger and attaches to Grayson's ligament. Now that lies below the neurovascular bundle. So what it does, if that is involved in Dupuytrens, the neurovascular bundle is lifted up and it becomes much more prone to be clobbered. Now, I reckon my chance of clobbering a neurovascular bundle is about 1%. In this guy, it will be higher. So the more deformity there is, and this guy's probably got, I would think, something like 120 or perhaps 140 degree contracture of the PIPJ, and the chance of damage to the digital nerve is higher the worse the deformity. I would do a very similar procedure. I don't think that there's any point whatsoever in offering him a percutaneous release. I don't think there's any point whatsoever in offering him Xiapex. Neither of these will work. I think you need to do a formal operation. I think you do need to consent him, although I wouldn't necessarily do this, but consent him for a skin graft, so a full thickness skin graft. The incision is done approximately in the palm, and I do exactly the same thing. In fact, it will be a longitudinal incision. It will go all the way up the finger, but I won't be able to do that to start off with. So you start off with your palmar incision, you raise your skin flaps, you identify your digital nerves, make sure you avoid them, and then you cut the Dupuytrens tissue. Now, I would hope, because it looks to me, although this guy's got an MPJ contracture as well, although again it's difficult to say, but that, if you release it in the palm, you'll get the MPJ contracture out. Now that will leave you with your PIPJ contracture. So as you've extended the finger, you're then able to actually release the PIPJ. And again, it's a longitudinal incision up the finger. You found the digital nerves proximally, and I just trace them up distally and take as much as disease as you possibly can. I should have said that in counselling this fellow, you're never going to get that finger straight. I would hope to get him out to something like about 30 or 40 degrees at the PIPJ. You might get them out straight, but it's unlikely. And I do think you have to say to the patient, I always say that it's a deal between the patient and myself. I'm very happy to try and do the hard work and get the finger straight. They have to make sure that they keep it straight. They are the only people with the aid of the physiotherapist that can keep it straight. My post-op management is that I put them in a splint or a heavy, unsavoury looking plaster that's very effective but doesn't look very nice and it's very heavy. Within 48 hours they see my physiotherapist, they take the dressing down and they put them in a nice hand-based splint. They exercise 4 times a day, so they come out of the splint 4 times a day. And as soon as they are able to get their fingers down to the palm, that's what we call gross composite flexion of the palm, then they're able to not use the splint during the day, but they have to keep the splint on for at least 3 months at night. That's another incentive, so I try and give people incentives. I say that, look, if you get the splint off, say if you do your exercise and get the splint off, then you're going to be able to drive. Revision cases I almost always do use a full thickness skin graft. Now whether that makes any difference or not, I don't know, but I don't think that I'd ever use a full thickness skin graft as a primary procedure, but this guy, because of that deformity, I'd warn him that I might. In order to do a full thickness skin graft, what I do is you almost always end up getting macerated skin around the base of the finger, and so that skin you have to excise. Now when you excise that skin, I then take a swab and put it on the area that's been excised. Now that has got some degree of bleeding to it, and that gives you a template for how big your graft will be. So I then put some big dots using a marker pen around the area of the size of the thing with a blue marker pen, and then I dab the blue marker pen over the antecubital fossa, because that, I think, it reliably gives good skin that has not got any hair in it, because unfortunately you don't want to leave someone with a hairy palm. I think that's probably the second sign of madness, and that's not something you want to give to anybody. That graft is sewn in, and I sew that in with some 50 monocryl. I tend to put a K-wire across the PIPJ when I do that to immobilise it, so that you immobilise the area so the skin can take. That wire I take out after 2 weeks. So the physiotherapy in a case that has a full thickness skin graft would not start for that 2-week period, although they would have a splint made by the hand therapist. I'd always try not to amputate the digits. I think that certainly the digits that are most commonly involved are the ring finger and the little finger. And the little finger is hugely important for your power grip. So if you can avoid doing an amputation, that's definitely the way. If you've got a flexion deformity of your finger, which is a recurrence, that will enable you still to have a very good power grip. And in fact, golfers love Dupuytrens because it actually helps them grip their stick a bit better. So I'm really anti doing amputations, if at all possible, almost anywhere. Because unfortunately, the nerves that go down the finger are all purely sensory nerves. And if you cut sensory nerves, they give problems. They give neuromas, and there are nerves that you really have to avoid. And sensory nerves are those, and it's the same in the hand, in the radial nerve in the wrist, the long saphenous nerve in the leg. All these nerves give huge problems when they're purely sensory. So I really try and avoid doing amputations at all possible. If I'm going to do it, I do a ray amputation. So I don't, and people quite commonly want to say, oh, well, can't you just, if you've got a deformity of your PIPJ, say of 90 degrees, they say, well, can't you just chop it off at the stump? Now, that I think is not a great idea, because that stump gets in the way, and also I think cosmetically it doesn't look very nice. In addition to that, the nerves, if you cut the finger off at the PIPJ, there's nothing to bury them in, and I think that if you're going to do an amputation, you should bury the nerves in some form of muscle somewhere, which is much easier to do in the palm, because there are obviously some muscles in the palm which you can do that. And that, I think, does help prevent neuroma formation. It doesn't stop it, but I think it does help. Now we're going to talk about Z-plasty. Are you happy with this, yes, Dave? Yeah, okay. Now I'm going to draw on young John's finger. Now, so I'm going to make an incision here for my. So I shouldn't do it on this finger, should I? Oh, bugger it, I've done it. So I'm making an incision there. That's the incision I make to do a Dupuytrens of an index finger, which is quite a rare finger to get Dupuytrens in, but that's the incision I use. What I then do is I make what I call a Gibbey incision here, so I cut from here to here, straight across, don't sew it up, it's left open, and that's a tension relieving device. If I'm going to do a Z-plasty, and I'm afraid that most of the books describe a Z-plasty, and I just never found I could do it until someone told me a really simple way of doing it. You do a Z-plasty where there's most skin, and there's most skin over the middle of the phalanx, so certainly the proximal phalanx, and also you can get some skin over the middle phalanx, but there's more skin here. That's where you want to do your Z-plasty. What you do is you put a line in the middle, or a dot in the middle, in the mid-axial line, either side of your finger, like that. So you have two dots. You then, all you do is you join one of them distally up to your line, and you draw one of them proximally up to the line of your scar. Note that this angle is 90 degrees. Okay, you get that angle, although if you draw it to a direct line, it wouldn't be 90 degrees, but try and make it 90 degrees, because then you get skip necrosis. Then you've got two flaps. That one moves over there, this one moves over here. And it's just so simple.